Hi everyone. I'm going to discuss about congenital hypothyroidism. I will discuss congenital hypothyroidism based on the guidelines by Indian Society of Pediatric and Adolescent Endocrinology. Congenital hypothyroidism is a preventable cause of mental retardation and the incidence is 1 in 1000 live births in India. It is also seen most commonly in newborns with Down syndrome and with congenital heart diseases and cleft palates and who have renal, skeletal and gastrointestinal anomalies. The causes of congenital hypothyroidism are mainly two types. Either it may be permanent congenital hypothyroidism or temporary congenital hypothyroidism. Permanent congenital hypothyroidism may be due to thyroid dysgenesis or dysharmogenesis or TSH resistance or central hypothyroidism. Whereas temporary congenital hypothyroidism may be due to TSH receptor blocking antibodies or due to maternal antithyroid drugs or due to hypothyroxemia of prematurity or TBG deficiency or iodine deficiency and excess or because of liver hemangioma. The important thing in congenital hypothyroidism is about screening of the congenital hypothyroidism. For screening, we have to collect either a cord blood sample or else a postnatal sample after 72 hours of age. In some newborns, a second screening is also needed after 2 weeks of age or 2 weeks after the first screening test. Those are like preterm babies or those are with low birth weights or sick preterms or multiple births or the first specimen which is collected between half an hour to 4 hours of life. Initially, when you collect blood sample from cord for TSH, if it is less than 20, then it is called normal. If it is more than 20, you have to send confirmatory sample at 72 hours of life. Whereas if the TSH sample is more than 20, in it, if it is more than 40, you have to start thyroxine there itself, and we should uh, check for any imaging abnormalities. After sending 72 hour of life confirmatory sample, if T4 is low and TSH is more, then we should start thyroxine and we should do imaging for the etiologies. And if it is low T4 and normal TSH, we should straight away start thyroxine, and this is due to central hypothyroidism. If it is normal T4 and high TSH, should repeat the TSH value after 2 weeks. If TSH is less than 10 after 2 weeks, then it is normal. If TSH more than 10 after 2 weeks, then we should start thyroxine. Then, if T4 and TSH is also normal, that is a normal entity. Next, imaging. For imaging of thyroid gland, we use ultrasonography and scintigraphy. In scintigraphy, if iodine 123 isotope is available, we should prefer iodine 123 isotope over technetium pertechnetic scan. First, initially, we should do ultrasonography of thyroid gland. If it is in ultrasonography, there is an absent gland, should go for thyroid scan, that is with scintigraphy. In it, if it is there is no visualization of thyroid gland, it is called athyrosis. There is an ectopic visualization, it is called ectopic thyroid gland. Whereas it is a small gland on ultrasonography and on scintigraphy it is absent or reduced uptake, it is called thyroid hypoplasia. Whereas if there is enlarged gland on ultrasonography and there is increased uptake on thyroid scan, it is due to iodine deficiency. And if there is decreased uptake in thyroid gland only, it is due to maternal antithyroid drugs. If it is due to decreased uptake in thyroid glands, salivary glands, and gastric mucosa. It is because of sodium iodine supporter gene mutation. If there is normal uptake, it is because of dysharmogenesis. The thyroid gland is normal in size in ultrasonography, but on thyroid scan, if it is due to increased uptake, it is because of iodine deficiency. And there is no uptake on scintigraphy, it is because of thyroid binding inhibitory immunoglobulins, which causes central hypothyroidism. And there is no uptake in thyroid gland, salivary gland, gastric mucosa. It is because of sodium iodine supporter gene mutation. And if it is decreased uptake, it is because of TSH receptor resistance. And if there is normal uptake, it is because of peripheral central hypothyroidism. Next, treatment. We should initiate treatment as soon as the diagnosis is made and as early as first 2 weeks of life to have a better neurodevelopmental outcome. So, goal of the treatment is we should normalize free T4 or T4 within 2 weeks and TSH within 1 month. This is the goal, and we should expect these values to be returned with a free T4 and T4 should return to normal by 2 weeks and TSH to return normal by 1 month. And the dosing is like this. It's 10 to 15 microgram per kg per day. You should start the dose at higher side as always, and the dose should be titrated to maintain the free T4 T4 in the upper half of the normal range and TSH in the adult normal range, the laboratory values. Should be given orally and should be administered daily on empty stomach actually. We should avoid co-administrating with iron and calcium. We should do X-ray of knees as soon as diagnosis is made, because um, if there is an absence of the lower femoral epiphyseal center, it indicates severe congenital hypothyroidism, and it correlates with the lateral intelligence and motor scores. That it means like if there is an absence of the lower femoral epiphyseal center, uh, child may have mental retardation and developmental delays in the future. And we should do universal hearing screening and regular hearing assessment in the OPDs throughout the childhood. Then, how do you follow up a child with congenital hypothyroidism on treatment? The first follow up should be done at 2 weeks after starting the treatment, because we expect normalization of free T4 and T4 at this age. At this age means at 2 weeks after starting of the treatment. The T4 is low, we should increase the dose, and if T4 is normal, the dose should not be decreased also. Then second follow-up we should do at 1 month after starting the treatment. There we expect the normalization of TSH. After the second follow-up, we should do further follow-up as like this. Every 2 months till the 6 months of age, and every 3 months from 6 months to 3 years of age, and every 3 to 6 months till growth and puberty is completed. And one thing, if we do any dose change, we should again follow up with the thyroid functional test after 4 weeks. And some people will have doubt at when to take the sample for the thyroid functional test. So it's better to take sample before taking the levothyroxine tablet, or else after 4 hours of the ingestion of the tablet. The babies with possibility of transient central hypothyroidism should be re-evaluated at 3 years of age. This is a follow-up. And thank you. This is a short lecture, and I will do the short lectures regularly. Thank you. Keep encouraging me.